Good morning, everyone. We're getting close to the 11:30 start. We're just going to give it another minute or two as additional people join in. Thank you so much for tuning in. We'll begin shortly. Good morning, everyone. We see a number of people are still joining, so we're just going to give it another minute and then we'll go ahead and get started in just a few moments. Thank you so much for joining in. Welcome, everyone, to the Adventist Health Policy Association webinar on the Inpatient Prospective Payment System Final Rule. I'm Julie Zabak-Aldinger, and today with me I have Susanna Molina and Cherie Danielson. We are a few members of the public policy team for AHPA, and today the team is going to be sharing with you key proposals in the final IPPS rule. Before we get started, I just want to take a moment to do a brief refresher on who is AHPA, what is the IPPS rule, and then talk shortly about some key trends in this rule, as well as how this fits into the broader policy landscape. The Adventist Health Policy Association, also known as AHPA, is a coalition of Adventist healthcare systems united behind supporting the entirety of a person. You see the various members that make up AHPA in this coalition, and together we advocate in a unified voice for key public policy issues. And IPPS houses significant public policy changes. So IPPS is a rule that sets the reimbursement rates for Medicare inpatient payments. This is an annual rule. It also includes updates on key Medicare quality programs such as IQR and the Hospital Readmissions Reduction Program, as well as other programs that you see on your screen. Now, it's important to remember that this is a final rule, so all provisions are final. The rule and its provisions are effective as of yesterday, October 1st, unless otherwise stated in the rule. So some of the provisions that my team members will be sharing, they will highlight if it is a different date of an effective date other than yesterday, October 1st. Before we dive into the specifics of the rule, I just want to take a few minutes to talk about the broader public policy landscape. And I just want to highlight 4 key trends that we see in this broader public policy landscape in which these rules are really being drafted within. So one is lowering costs, that pressure to reduce costs. And we have seen this for the last several years in healthcare, that policy is really geared towards curbing the high cost of healthcare that has been born out of a predominantly fee-for-service system. The need to lower cost is manifesting in policy changes such as lowering reimbursement or driving more services to value-based payment programs or arrangements. Second, we are seeing a trend of really a focus on consumers. So Health and Human Services has had a keen focus on consumers. In particular, how can we provide more convenient care, such as providing closer to home care? In terms of policies that we may see related to this, you could think of something like telemedicine. Also, with lens on the consumers, there is a growing focus on lowering the cost of care for consumers and to really ensure that they are fluent and understand the cost and quality of the care that they are consuming. And so when we think about public policy that will be developed in this light, think about policies on transparency. And we're going to be talking a lot more about that in just a moment. Third, there's COVID-19 in terms of policy trends. Over the last several months, as the global community has really been grappling with COVID-19, we have seen a push in policy related to this pandemic. There have been efforts to loosen and relax some of the existing policy infrastructure, really to enable providers to act quickly in response to the pandemic. Additionally, during the pandemic, there has been consideration to either delay some reporting periods or to change formula methodologies in order to account for the pandemic. And lastly, there is an emphasis to increasing transparency. And this is true in policy that impacts hospitals, providers, and payers. And this issue is front and center in the final IPPS rule. Price transparency is really top of mind of both consumers and policymakers. So however you tune into your news, whether that's in a physical newspaper, maybe a podcast or an Instagram, you would probably see headlines such as those on your screen right now. Most recently, a RAND study has highlighted that hospital charges are often much higher for private insurers than in Medicare. And all of this is really fueling some of the changes in policy. And as this swelling in public consciousness is really playing out in public policy development, there have been considerable policies that have come out. And I just want to take a moment to really highlight some of those on your screen, and then my team will be going into it in more depth. So there have been multiple executive orders by the Trump administration around price transparency. Now, it's important to note that executive orders are not necessarily legally binding on their own. Rather, rules are going to have to be promulgated or congressional action needs to be taken to enact on those executive orders. Now, there have been a couple executive orders on price transparency. In one, it was stated that policy should be developed around publicly posting charges and negotiated rates. Additionally, that there should be a stop to surprise billing. In a more recent executive order, President Trump has indicated that there must be modifications to the Medicare fee-for-service system to reflect MA and private insurance rates. So it is no surprise that regulations have been developed to address these broader policy demands as articulated in the executive orders. Last year, we saw the final price transparency rule. There were demands that hospitals share their negotiated rates, and a failure to do so would result in a civil monetary penalty. And here in the final IPPS rule, we continue to see developments in price transparency. CMS has finalized policy proposals for hospitals to report the median negotiated charges for MA plans. Moreover, CMS has signified that starting in 2024, hospital payments will be adjusted to more closely reflect MA payments. So you'll be hearing about these policies in more depth from Susanna very shortly. The key message here is that policy proposals, especially related to price transparency, are really part of a bigger picture. Hospital reimbursement continues to be under scrutiny, and consumers are demanding to know more about what they're being charged, and Medicare fee-for-service payments are most likely going to be reduced as a account of this increased scrutiny. So Susanna is going to spend some more time really breaking apart what proposals are in IPPS versus some of those other policies that I just touched on. And with that, I'll turn it over to you, Susanna, who is going to provide more specifics on transparency and IPPS as a whole. Thank you.
Thank you, Julie. So this slide provides an overview of those issues that our team will be covering in today's presentation. That includes changes to inpatient payments, price transparency, add-on payments, changes to disproportionate share hospitals, as well as changes to CMS's quality programs. There will also be an opportunity at the end of the webinar to raise any questions related to the issues addressed in today's presentation. So in this year's rule, CMS is proposing to increase inpatient payments by 2.4% instead of 3% as originally proposed in the rule. There will be no productivity cut related to the Affordable Care Act. These proportionate share payments are going to be decreasing by 0.7% instead of the originally proposed of 6.4%. which is a decrease of $61 million compared to fiscal year 2020. And my colleague Sherry Danielson will be talking more about that in future slides. There's also a macro documentation and coding adjustment of 0.5%, and LTAC payments are also slated to increase by 2.3%. As Julie mentioned earlier, price transparency is a big priority to the Trump administration. As you may all remember, in 2019, CMS finalized the Hospital Price Transparency Final Rule, which becomes effective on January 1st of 2021, so next year. That policy requires hospitals to make public their standard charges for all items and services provided in the inpatient setting, including negotiated charges, in a single machine readable format. It also requires hospitals to make public a consumer-friendly list of negotiated charges for at least 300 shoppable services. And then failure to comply with this rule beginning on January of next year will result in a civil monetary penalty of $300 a day. After that rule was finalized, in October of last year, President Trump issued an executive order that expands upon that policy. The order instructs the Department of Health and Human Services to modify Medicare fee-for-service payments so that they more closely reflect the prices paid for services in Medicare Advantage and the commercial insurance market. So in compliance with that mandate in this year's IPPS rule, CMS included a proposal to require, beginning in January 1st of 2021, for hospitals to report in their cost reports their median negotiated charges by MSDRG for all Medicare Advantage and third-party payers. And this requirement would apply only for items and services provided in the inpatient setting. The data collected from hospitals' cost reports would then be used to inform inpatient payments beginning in fiscal year 2024. So in the fall of 2023, CMS would adjust hospitals' inpatient payments based on the data reported by hospitals in the cost reports. Now, this policy only applies to hospitals that get reimbursed under the inpatient prospective payment system. It does not apply to critical access hospitals or hospitals in Maryland. And this is an example that CMS included in the proposed rule to illustrate how that new policy would be implemented. Hospital A has negotiated 4 different payer-specific charges with 4 Medicare Advantage organizations for the hypothetical MSDRG 123. Therefore, in the cost report, that hospital would include the payer-specific negotiated charges of $7,300, $7,400, $7,600, and $7,700. Based on that information, the median negotiated charge for MSDRG 123 would be $7,400. That would be the only information that hospitals would be required to report in their cost report. Notice that unlike the price transparency rule of 2019, this policy does not require hospitals to publish how much each payer is reimbursing them. So hospitals would not be required to say charge with Humana is X or with Blue Cross is X. They would only be required to report a median negotiated charge by MSDRG without any identifiers. In our comments to CMS, AHPA stated that we do not support the proposed policy because charges paid to Medicare Advantage organizations are largely based on Medicare fee-for-service. So that policy would not actually achieve the administration's goal of capturing market rates. We also recommended for CMS to explore other payment mechanisms to better capture the cost of truly providing care to Medicare patients. Now, in response to our comments and the comments submitted by others, CMS finalized their proposal, but with one modification. And instead of applying this policy to all third-party payers, hospitals would only have to report the median negotiated charges for Medicare Advantage. And then everything else stayed the same. This policy would apply to cost reporting periods ending on or after January 1st of 2021. And then beginning in fiscal year 2024, CMS will adjust the inpatient payments on that information reported in the cost reports. Now, also something important for you to know is that even though the price transparency rule of 2019 is currently being litigated, the statutory authority that CMS claimed in the price transparency rule is different than the one being used with this final policy. So even if the price transparency rule of 2019 was overturned, that would likely not impact this finalized policy, and it would have to be challenged through a separate lawsuit. In terms of compliance, unlike the price transparency rule of 2019, CMS is not imposing any civil monetary penalties for failure to comply with this rule. However, because under Code 42 of the federal regulations, hospitals are required to include in their cost reports everything that is required by the Department of Health and Human Services. Failure to include this information in the cost reports may result in the withholding of inpatient payments. So what's going to happen next? According to CMS, they will conduct further analysis based on the market-based data received, and then they will provide an opportunity for the public to comment on that analysis, which may include consideration of any unknown impacts of the COVID-19 public health emergency. So prior to fiscal year 2024, hospitals and health providers in general will have an opportunity to look at the analysis and provide comments to CMS. And the methodology that CMS uses will likely may be different before the policy is implemented in fiscal year 2024. And now my colleague Cherie will be speaking about disproportionate share hospital payments.
Thanks, Susanna. So disproportionate share hospital payments, or DSH payments, like we call them, have a few changes in this year's IPPS finalized rule. Just a quick refresher, we always have our base DRG payment, and then the disproportionate share hospital payment supplements that as a percentage add-on. And this is supposed to really help hospitals offset the cost of caring for more expensive and lower income patients. DSH payment amounts are based on worksheet S10 data. In the proposed IPPS rule, CMS originally floated a proposed $11.6 billion. In the final version of IPPS, we see that the finalized estimated payment is actually $12.1 billion. Even though this is an increase from the proposed version, it is still a reduction of about $400 million when compared to fiscal year 2020. However, it's not as bad as it would have been, and this is because CMS took into account stakeholders' feedback, including AHPA's, saying that this year is just totally unprecedented for hospitals, and we are facing unique challenges in our most expensive patient populations often. So they've adjusted the uncompensated care amount to account for the COVID-19 pandemic. There's no change to the data requirements for this year or the data usage for determination. CMS is going to continue to use the most recently audited cost reports to make DSH payment determinations. So talking just a little bit more about DRG payments in general, in Medicare, the MSDRG provides a way to classify a patient's hospital stay and the cost of giving them that stay while they are with us. In the finalized version, CMS is going to adopt a 0.5% adjustment to the standardized amount of Medicare payments as required by AHPA. This slide is the proposed MSDRG updates that were floated earlier this summer by CMS. CMS proposed to create a new MSDRG 018 for CAR T-cell therapy, and also to make 2 more new MSDRGs for hip replacement, 521 and 522. These are for those with a principal diagnosis of hip fracture, and these would be added to the post-acute care transfer policy. Now, in our advocacy, we advise CMS of the potential impact that these new groups could have on bundles, particularly CJR, as the episodes of care that these MSDRGs would be attracting or would be holding are currently held in the CJR model. CMS did take this feedback into account. So here's the finalized version. We still see it's still the same 3 MSDRGs. However, CMS has agreed and they promised us that they are going to modify CJR to account for these new groups. Now, these exact updates are still pending. We are still waiting for a final rule. So we will absolutely let our AHPA members know as soon as we get the CJR final rule. And we'll be looking out to see if these 2 new MSDRGs are in fact rolled into it. The other point to highlight for AHPA members is that there's a new deadline now for requesting changes to MSDRGs. October 20th is the last day to get those. CMS is also adopting 9 principles related to changing the severity level of MSDRG, and these are listed on the slide. And these are really meant to be meaningful indicators of a hospital's expected resource use by a secondary diagnosis. We also have a few updates to ICD-10 codes. The IPPS final rule includes changes to nearly 600 ICD-10 codes. We have 490 codes added, 47 codes are revised, and 58 codes will be deleted. If you're interested in these codes, tables 6A through 6K and 6P of the final rule have tables with links to all of these codes. And if you are working off of, or you're not working off of the web version of the Federal Register, just drop any of us a note or send us an email on the side and we can send you a link that will jump you right here. We also have a few changes to new technology or NTAP payments. During our previous fiscal year, CMS established a new alternative new technology add-on payment or NTAP pathway for certain technologies, and they also finalized higher payments. This is how the process works. If you want to qualify for an NTAP or new technology add-on payment, it has to be new, cannot be substantially similar to the existing tech, and must have FDA approval in the past 2 or 3 years. Cost, it has to be costly such that the applicable DRG rate is determined to be inadequate. And it must meet the parameters outlined in the fiscal year 2020 rulemaking that shows it's demonstrating substantial clinical improvement as defined by CMS. Previously, eligible antimicrobial products could receive an NTAP after they got FDA approval, provided that the approval occurred before July 1st. Now, CMS is going to let products receive conditional add-on payments as well for those who do not meet that July 1st deadline. This section also continues NTAPs for 10 products, discontinues NTAPs for 8, and approves 9 through that alternative new pathway that we just talked about. If you're interested in these, all AHPA members should have access to the PDF version of these slides, and so click on the hyperlink and it will take you right to the full list. And now Susanna is going to walk us through some changes to the quality programs.
Thank you, Sherry. Oops. Okay. So in this year's rule, because of COVID, CMS is not adding or making any significant changes to the quality program, so no new measures and no measures removed. As a reminder, there are 2 types of quality programs, those that require mandatory quality reporting and those in which hospitals have to report and then they are penalized based on their scores and performance overall in quality measures. This slide provides an overview of those policies that CMS finalized, which impact different programs. So for the hospital acquired condition and the hospital readmissions program, CMS is adopting an automatic performance period. For the HAC, that is a period of 24 months, and for the readmissions program, that is a period of 3 years. Every year, CMS had included a proposal for a specific applicable period, and moving forward, instead of making the same proposal every single year, CMS will just adopt that 24-month and 3-year applicable period consecutively without seeking comments on that. CMS will also require for hospitals to publicly report ECQM's data beginning in calendar year 2021, and that will be applied to the Inpatient Quality Reporting Program and to the PI program, or Promoting Interoperability Program. CMS is also finalizing its proposal to increase the number of quarters of ECQM data that is reported, so that by calendar year 2023, hospitals would report 4 quarters of data instead of just 1. And that is applicable to IQR and the PI, or Promoting Interoperability Program. And then for both IQR and the Hospital Acquired Conditions Program, CMS also finalized its policy to align the hospital selection for data validation. As a brief overview of the Inpatient Quality Reporting Program, in this program, hospitals are only required to report data to CMS, and they're only penalized for not reporting data. They are not penalized based on their performance. Also, measures that are used in the IQR program are often used in the BBB program. So the IQR program serves sort of like as a menu of options for CMS when looking at future measures to include in BBP. As mentioned earlier, CMS is increasing the number of quarters that hospitals must submit gradually. So for fiscal year 2023, hospitals will be required to select 2 self quarters instead of 1. And then by fiscal year 2025 or calendar year 2023 reporting, that would be all 4 calendar quarters. The submission deadline does not change, so that will remain the February of the following year, of the following calendar year. Beginning on fiscal year 2023, CMS will also publicly report this ECQM data on the Hospital Compare website. Some commenters asked CMS to delay this policy because of COVID-19, but CMS stated that hospitals have been successfully reporting ECQMs, and that based on the 2017 and 2018 data, about 95% of hospitals have been submitting this data successfully to CMS, so they did not see a reason to delay the publication in Hospital Compare. And as with other measures that go into Hospital Compare, hospitals will have 30 days to review the data that is included before it actually appears on the website. For data validation, CMS is finalizing its policy to align the data validation process for both chart abstracted measures and ECQMs. For the hospital acquired program, this is a pay for performance program that reduces total payments by 1% to those hospitals scoring in the bottom quartile. There are two domains, domain 1, which includes the PSI 90 measure, and domain 2, which includes the NHSN hospital acquired infection measures. Nothing in this rule is changing the measures on those domains or the weights. Everything is staying the same, including the submission deadlines. However, CMS is requiring for fiscal year 2021 a PDF submission for medical record data instead of any paper documentation. Beginning of fiscal year 2023, as I mentioned before, there will be an applicable period of 24 months, and then the data submission quarters will be the same as the IQR program also. So for 2023 data validation, it would include data for quarters 3 and quarter 4s, and for 2024 data validation, it would include data from calendar year 2021. And then beginning in the data validation process for fiscal year 2024, CMS could choose up to 400 hospitals instead of 200 for the validation process. And now Cherie will be speaking about the readmissions program.
Thanks, Susanna. There we go. All right, so the readmissions program is intended to incentivize hospitals to reduce readmissions. Hospitals face a potential 3% reduction in payments. This year, we don't have any major changes to the readmissions program. However, we want to flag for our membership just to stay on the lookout. The first 2 quarters of 2020 data may be excluded from their performance calculations for this program. CMS is expected to include their final decision on this in the COVID-19 data reporting final rule. So we will be sure to watch out for this. And for those of you who are subscribed to the policy brief, we will absolutely make sure that we put an alert in there when this drops. We have we have no changes actually to the value-based purchasing program. However, just as a reminder, the value-based purchasing program gives a 2% risk of inpatient-based operating payments, and it's based on whether or not you provide high-value care. However, IPPS is making some changes to the Promoting Interoperability program, although they are minor. Promoting Interoperability, also known as meaningful use, requires eligible hospitals to report on objectives and measures in order to be considered a meaningful EHR user, and those who do not comply face a payment reduction. This year, the continuous 90-day reporting period will be extended to 2022. The query of the PDMP measure will be maintained as voluntary for 2021. And there's a slight renaming of the Health Information Exchange objective measure. But the biggest change here to the PI program is that the final rule progressively increases the number of quarters that a hospital must report. So now we are moving from 1 quarter of data to 4 quarters of data over a 3-year period. This is just a rundown of how the program works. Just want to highlight that that query of the PDMP is still for bonus points. It is not mandatory as was originally proposed. The final rule also kept the same clarifications to bad debt standards as the proposed version. We have to make reasonable collection efforts and prove that we are making reasonable collection efforts to CMS. And they have to meet these definitions of what reasonable is. The one that has gotten the most discussion here is this requirement that we do things the same basically for everyone. So if we refer all private payer bad debts over $100 to a collections agency, we have to make sure that we are doing the same thing for Medicare bad debts. And then the rule also includes clarifications on bad debts for dual eligibles and indigent non-dual eligible beneficiaries as well. And then finally, the final rule requires that providers submit patient records electronically to beneficiary and family-centered care quality improvement organizations.
And this takes us to the end of the webinar. If there are any questions, you may include it on the chat box, or you may also unmute your lines. We'll give everyone a few minutes.
Going back to that bad debt item, is there a significant change there? Like, it seems like that stuff that we were doing before, like I'm just trying to pick up what's the incremental change there?
Yeah, this is actually does not appear to be a change. I think some commenters just asked for clarification.
Gotcha. Okay, that makes sense. What's the significance of that last thing about sending the records to the whatever those are? I don't really know what those are. BFCC's QIOs.
So team, this is Susanna. So currently that information is being sent, well, not currently, some hospitals may be sending that information on a paper format. And the only change here is that CMS is requiring it electronically. So this requirement is already in place. It's just that they want to make sure that hospitals transition to electronic. And then the quality improvement organizations, they are the ones that usually provide education to providers. So for example, with the 2 midnight rule, they look at that as well.
Okay, thanks.
Any other questions or comments? Okay, well, thank you everyone for joining the webinar and for your time this Friday. This webinar has been recording and we will be providing the recording on the next policy brief that will be issued within the next 2 weeks. If you're currently not subscribed to receive the policy briefs, please make sure to send us an email and we'll ensure that you receive that newsletter moving forward. Thank you.